Good morning. So I want to thank the ABGN for inviting me to participate in this session, and particularly to Kwaku for all of your tireless work in putting together not only this presentation, but keeping us afloat and keeping us on task as we move forward. This presentation is about a specific model of mobilization in a specific country, mobilizing Black Americans in the United States. Calvin Rolark, the founder of the Black Fund, said, "Nobody can save us from us but us. Nobody can save us from us but us." The point being that if you are going to solve any challenge in a community, it cannot be done without the leadership of that particular community. The Black AIDS Institute was founded in 1999. We are the only national HIV/AIDS think tank in the United States that focuses exclusively on Black people. Our motto is to end the AIDS epidemic in Black communities by engaging and mobilizing traditional Black institutions, leaders, and individuals in efforts to confront HIV. We do four things. We do information dissemination primarily through Black media. We are the single largest provider of original HIV content in the media today, generating over 865 million media impressions in 2013. We do training and capacity building. We're going to talk about our training capacity building project, largely in increasing HIV science literacy in Black communities. We do policy work, both analyzing and making recommendations on both public and private sector HIV policy. And we do mobilization and advocacy from a uniquely and unapologetically Black point of view. My favorite phrase on the planet, from a uniquely and unapologetically Black point of view. We are at a deciding moment in the trajectory of the AIDS epidemic. We have the tools to end the AIDS epidemic. Now, a number of folks are talking about getting to zero, but how do you do that? In Black communities in America, we created this kind of roadmap, where you look at where we are. My grandmother used to say, if you don't know where you are, there's no way in heck. She didn't say heck, but there's no way that you can get where you want to go. So you have to know where you are. And we have these new tools. We have better diagnostic tools. We can tell you, you can find out your HIV status now in a short period of time. You can do it without blood. You can do it without needles. It's painless. And you get information that can save your life. We have better surveillance tools in many parts of the world, particularly in the United States, where we can identify the hot spots of the epidemic, sometimes down to the census tract or the zip code. We have better treatment tools. At this conference, we were talking a lot about treatment as prevention, but as a person who's been living with HIV now for 35 years, I am never, ever, ever forget that treatment is also treatment. And so we have better treatment tools that help people stay alive longer and increases our life expectancy as well as our quality of life. We have better prevention tools. Now when we combine both biomedical interventions and behavioral interventions, we actually have the ability to move much faster, much farther down the prevention road than before, and we have better policy tools. But none of those tools matter if you don't have folks on the ground to make a difference. And so the roadmap, at least in the United States, involves a number of stops. Number one, the Affordable Care Act. For those of you who are not from the United States, it's probably a surprise. The United States, is one of those countries one of those developed countries where basically healthcare is not a right. Now, that in one of the richest countries on the planet, people actually die because they can't afford health care. And the Affordable Care Act provides a pathway for people living with HIV and other illnesses, for that matter, to actually be able to afford the care they need and deserve. We have to deal with disclosure issues. There are criminalization laws in the United States that undermine our ability to reach people to provide services that they need. We have to address those criminalization issues. We have to address the stigma associated with HIV. But we also need to find ways for those of us who are living with HIV to disclose our HIV status so that we can develop the kind of supportive networks that we need to provide the care we need to adhere to our regimens and to live the lives that we deserve. And of course, we have new biomedical interventions that can help us in our prevention path. One of the challenges in the United States is that many community-based organizations do not currently have the infrastructure to respond to the new HIV paradigm. And so part of the challenge is retooling those organizations so that they can succeed in a post-biomedical world and in a world, in a post-AIDS Affordable Care Act world. One of the tools that we talk about in the United States is the continuum of care. This slide shows the differences, the disparities in care along the continuum based on race. Now, in the United States, across the board, we are roughly diagnosing around 80 to 85% of the estimated 1.15 million Americans living with HIV. Not good enough, but not bad. But then, after that, we roughly drop off around 20% of those folks and linking them to care. So we're testing them, but we're not linking them to care. But at every step of the continuum, linkage to care, retention to care, going on ARVs, and finally achieving viral suppression, Black Americans do poorer than other racial ethnic groups. White Americans on average are reaching a 30% viral suppression, which means they're getting optimal care. On the other hand, Black Americans are only reaching 21%. One of the things that we talk about at the Black AIDS Institute is that AIDS in America is a Black disease. Now, mind you, it is not just a Black disease, and it's no less tragic no matter who is infected, no matter who gets sick, or no matter who dies from this disease. But when you look at the numbers, when you follow the numbers, when Black Americans represent 10 to 12% of the U.S. population, and yet we represent nearly 50% of new cases and nearly 50% of the estimated 1.15 million Americans living with HIV, AIDS in America is a Black disease. When you look at the AIDS epidemic through the lens of gender, sexual orientation, age, level of education, or region of the country where you live, Black Americans, as exists in the rest of the world, bear the burden of the AIDS epidemic. If we want to talk about getting to zero in the United States or anywhere else, it is true. You cannot get there without Black people. If we lose the battle among Black people, we cannot win the battle to get to zero. We will not be able to end the AIDS epidemic in America or anywhere else. So then the question is, how do you make it happen? So Maya Angelou said, when we know better, we do better. When we know better, we do better. And so it's important to figure out what we know. And so one of the things that the Black AIDS Institute and our partners at the CDC, the National Latino Commission on AIDS, Johns Hopkins University, and the National Association of State Territories AIDS Directors, and Janssen Pharmaceuticals in 2012 and 2013, we conducted the first ever national KAB of the HIV/AIDS workforce. We wanted to find out what people knew about basic knowledge and terminology, what they knew about treatment science, what they knew about clinical science and biomedical interventions, what they knew about and how they were with familiarity and attitudes toward biomedical interventions. What we found out was that our AIDS workforce didn't know enough. On average, across all categories, we found a 62% competency. I have 2 adult children, and when they were in school, if someone brought home a 62%, they got grounded, okay? On basic science and terminology, we scored about a 76%. That's a C. So you didn't get grounded for as long. On treatment knowledge, only a 55% competency, and on clinical and biomedical interventions, only a 45% competency. So that means that when it comes to treatment and clinical knowledge, we are failing. The bedstones of our strategy to get to the end of the AIDS epidemic, our workforce, the folks who are charged with doing the work, don't know what they need to know. That 10 minutes certainly went by very fast. I will go as quickly as I speak. I will continue to go on. We saw some changes based on race. We saw that white Americans did better than Blacks and Latinos. White Americans on average is 66%. African Americans and Latinos scored around 59%. So here is our model. At the first place, we have to figure out what we know. And so the KAB and doing community readiness allows us to figure that out. Secondly, we have to be able to provide the technical assistance and the training to actually change the infrastructure in the communities. And then we have to go to activation. This model shows the model, and at the end, you see where we've been able to implement our model across the country. Our Keystones training program is our African American HIV University, where we took the lack of information that we knew the AIDS workforce knew. We created a cohort of folks, and we put them through a year-long training. I'll quickly just go through the data of that training. At baseline, the participants scored about a 57% competence, a little lower than the national effort. At the end of the first training, which is at the end of 30 days, they scored a 90% competency. They went away for 90 days, they came back, we did a new baseline, and at the end of the second training, they showed an 84% baseline. This is like now 6 months in. Then they went away again, and they came back for another booster training, and they scored an 87% competency at that. At the end of 10 months, when we did a final post-test, they scored a 92% competency. So what we found out is not only could people learn the information, they could retain the information, and most importantly, all of these folks had an obligation to then do trainings in their local communities. They had to conduct 3-day trainings in their local communities using the information that they learned. We did pre-tests in those trainings. On average, the people who came to those trainings scored around 47% on their pre-test. After the 3-day training, they scored around 85% in their post-test. So now we found out that people can learn it, they can retain it, and they can transfer the knowledge. They can teach it. Not only that, they can use the information to develop networks in their local communities. And so in our model, we have what we call the Black Treatment Advocates Network. And through this training program, we now have networks in 18 cities around the United States. Those networks are co-convened by the health department and an NGO in the local community. Each network has to have a minimum of 50 active members. Each network has to have an open, public meeting every month. They have to focus on 4 priority areas: treatment education, patient navigation, disclosure, and advocacy. Here are some examples of some of the programs and the projects that they are conducting around the country in these various areas, looking at the Affordable Care Act, looking at the AIDS Drug Assistance Program, looking at housing, in treatment education, looking at different ways of doing high intensity, medium intensity, and low intensity education. I want to thank a whole bunch of folks, but if you want more information about our program, you can reach us at the Black AIDS Institute. As a kind of an epilogue, one of the things that's disturbing that's happening in the United States is a systematic dismantling of the Black infrastructure to provide services and education and treatment and training in Black communities. The fundamental question is that the messenger does matter. But not just that the messenger matters, but an informed messenger matters. So we have to make sure that we maintain the infrastructure, now that we in fact have folks who look like the folks who we're trying to train, and that outsiders cannot do the work of saving our communities. Essex Hemphill said, "I want to start an organization to save my life." If snails, whales, Chrysler, and Nixon can be saved, then the lives of Black people are priceless and must be saved. We should be able to save ourselves. The day will come when this epidemic will be over. And when it does, it's important for them to know that we were not all monsters, that we were not all cowards, that some of us dared to care in the face of it. Some of us dared to fight because of it. And some of us dared to love in spite of it. Because it is in the caring and the fighting and the loving that we live forever. Thank you.